lunch. We have a bit
Late, yeah.
drowsy also. And the topic is management of neuropathic pain. I have devised for myself two rules of pain. First is that pain is an unpleasant sensation and an unpleasant experience. The second is that broadly pain has two subtypes, nociceptive pain and neuropathic pain, and neuropathic pain is the topic for discussion today. The third rule of two, for me, it is not mentioned in the books or in any journals at all. Spinothalamic tract, which conducts pain sensation, may be conceptualized as having two systems. The lateral system that projects to sensory motor cortex, especially parietal cortex, which is responsible for localization of the pain, number one, and appreciation of pain intensity, number two. And lastly, the medial system of the spinothalamic tract that projects to the anterior cingulate gyrus and the insular cortex, and these two regions are concerned with anxiety, fear, depression, that is emotional aspect of pain. And finally, my rule of two regarding treatment is that it requires not only treatment of pain, analgesics, but also addressing to the emotional aspect associated with pain. With these brief comments, I request my learned colleague, Professor Romesh Bhattacharya, to speak on the topic.
Respected Chairperson, Dr. Shankarnath Jha, Dr. S.K. Shomani, respected seniors in the audience, dear colleagues, it is a great privilege that I am here to talk about neuropathic pain, which is closer to my heart. Before going to that place, I first offer thanks to the Howrah Diabetes Starting Shooter Society, Romesh Bhattacharya, for repeatedly reminding me about the new art programs. Possibly diabetes is that area where all the specialists can meet. Starting from community medicines, neurologist, endocrinologist, ophthalmologist, ENT specialist, dental specialist, cardiologist, pulmonologist, nephrologist, gastroenterologist, urologist, vascular surgeons, skin specialist. So do you find any area of medicines where all these specialists can come together? No. It is the diabetes by which we can accumulate all the specialists, including physicians. So, now coming, this place is familiar to me. And this MDS is familiar to me also, because I have seen the faces which I know in the earlier. Now coming to the neuropathic pain, management of neuropathic pain is my topic. I have preferably selected neuropathic pain, not the diabetic peripheral neuropathic pain, thinking in mind that many of the diabetes patients can have other cause of neuropathic pain, almost 10 to 15%. So whenever we are dealing with neuropathic pain, not only think of diabetes only, but we have to think of other causes which are so much rampant in the community. Now, 20 minutes is not not a good time for covering the neuropathic pain. I have divided in the following part. So, disease can destroy the body, but pain can destroy the soul. This is the written by Bishop, and George Bernard Shaw once said, a person having toothache, nothing is more important than going to a dentist, even the world is tottering. So that is the pain. So that is one of the most important symptoms by which patient comes. But we rarely give that much importance to treatment of the pain. So, definition. The newer definitions, you can add only one thing, the associated or resembles with actual or potent tissue damage and describe in terms of such damage. So, for academician, this is the definition of pain. Dr. J. Bonica has introduced this pain medicine in international level at 1973. But he didn't know at that time that India is not far away. Within 12 years, we have our society, Indian Society of Study of Pain, which is known as ISSP. That was organized in 1985 under Dr. Akram Lal in Belarus. So already Dr. Somani has given a beautiful comment about the quality or type of pain. So nociceptive pain, it can be classified as somatic pain and visceral pain. Now, what is somatic pain? You know that when the patient suffers from arthritis, bone fracture, skin injury, all that is a somatic pain. What is visceral pain? Is the peptic ulcer disease and renal colic. So all these, or bladder, or endometriosis, cystitis, or endometriosis, they can cause visceral. And what is neuropathic pain? This is the topic of today, that due to damage of the nervous system. Either it may be central nervous system from brain to spinal cord, or it may be peripheral nervous system, root, plexus, peripheral nerve, or muscles. Now, what is idiopathic pain? Now there are some pain which we till now cannot explain, but they are common: fibromyalgia, myofascial pain syndrome, and irritable bowel syndrome. So, neuropathic pain can result from injury to neural structure. Already I have discussed. I may not be able to cover all the part of a slide. I may not be able to cover all the slides because of the time. So sometimes I will skip. Please forgive me. So what are the epidemiological things? Our chairperson, community medicine specialist is here. So painful diabetic neuropathy, post-traumatic neuralgia. Now two terms, HIV-related neuropathy and AIDS-related neuropathy. What is the difference? It is not that all HIV-infected person will be having AIDS. So HIV infection can itself produce neuropathic pain, and that has some separate type of treatment, like that of lamotrigine, carbapenems, and that sort of things, and also capsaicin patch. We will see it further. What is AIDS-related pain? That means when patients suffer from AIDS, there will be opportunistic infection that will produce various type of neuropathy. So these two terms are different. Trigeminal neuralgia, phantom limb pain, central post-stroke pain, which we often deal, although they are not that excruciating pain, but they are irritating in nature. And multiple sclerosis, we are diagnosing it regularly. Not to forget about cervical radiculopathy, about the lumbosacral radiculopathy. Those who are practicing and going to the rural areas, they know how much burden patients are facing from suffering. The cervical lumbosacral radiculopathy and cervical radiculopathy. Keeping in mind, 50 to 60% of patients can be treated by conservative management only. Not every cervical or lumbosacral radiculopathy needs surgery. So we have to differentiate it from other type of pain. Personally, I believe when a patient suffers from low back pain and leg pain, it's a very easy diagnosis, it's a radiculopathy. But it happens, the low back pain disappears. The only leg pain persists. So if we do not take the history, how it started, we can often miss it. And also, neuropathic pain has other character, burning, tingling, numbness, electric shock like. By that, we can differentiate whether that leg pain is due to somatic pain, arthritic pain, or that of neuropathic pain. Patient often feels that you are saying, আমার তো পায়ে ব্যথা হয়েছে ডাক্তারবাবু, আমার কোমরের বেড দিচ্ছেন কেন, কোমরের এক্সারসাইজ দিচ্ছেন কেন? So it started from the low back. Now it's going to the leg. That's why this is the character of radiculopathy. Well, a lot of study has been done for peripheral neuropathy, but radiculopathy is a neuropathic pain. So initially to start with, it may be somatic pain due to this inflammation, but later on it is due to neuropathic character. Now coming to the, obviously sleep will be disturbed, quality of life disturbed, anxiety and depression will come side by side. Unless we treat the pain along with this sleep disturbance, along with anxiety, depression, we cannot give them peaceful life. So every time a patient is coming to us, we have to diagnose the patient, whether we are truly diagnosing it, and we have to comorbidities. Because if we do not treat the comorbidity, patient will be not satisfied, and patient will go from one doctor to another doctor without any benefit. So what is neuropathy? There are a lot of things we know that, but keep in mind pre-diabetes, because sometimes pre-diabetes can produce peripheral neuropathy. We have pick up by their glucose tolerance test. Beware of subclinical hypothyroidism, that means some biochemical level. We can have hypothyroidism that can produce peripheral neuropathy. Chemotherapy, anti-HIV drug, so tongue twister, like of Girovidi, Stavudine, Diadenosine, all can produce. So that's why that has been replaced by new antiviral drugs. Now, small fiber neuropathy, these are the, if we think of a diabetes patients, we will, that they can produce varieties of neuropathy. First, it's a sensory motor neuropathy. Second, it may be acute sensory neuropathy. And there are cranial neuropathy. There are carpal tunnel syndrome. There are truncal radiculopathy. There are neuralgia paresthetica. There are peripheral sensory motor neuropathy. So by that way, patient can present. So diabetes mellitus can produce susceptibility to intracranial neuropathy, as like that of rheumatoid arthritis. They can also produce this. Now, there are so many terms, but I find This lowest three term is more useful. That is dysesthesia, it is painful, and paresthesia, it is non-painful, and allodynia. So allodynia is that much, it can disturb the sleep of the patient for whole night, because with the touch of the bed sheet, with the touch of the garments, that can produce allodynia. So this allodynia is due to central sensitization. So long-standing pain can produce central and peripheral sensitization, and that produces pain. So not to treat these patients SOS, you have to treat these patients round the clock. That is the advice of WHO. Not by analgesic medications, but there are a lot of medications available for neuropathic pain. Now, there are so many positive symptoms, there are very few negative symptoms. If you see that the somatic pain is always aching in nature and throbbing in nature, but what happens to neuropathic pain? This is always separate from somatic pain. There will be tingling sensation, prickling sensation, panorama of symptoms patient can produce: lightening, aching, knife-like, pulling, burning, electrical. So if you see that this type of quality is there inside the pain, then you must think of neuropathic pain. Now numbness, it is usually post-stroke patient, and I have seen particularly side block migraine, because I have interest in migraine and neuropathic pain. Those patients who suffer from recurrent migraine attack, particularly unilateral, in the same side, right and right. Those patients, there are subgroup of patients of those, they can develop unilateral pain in right upper limb and right leg and also right trunk. So this is migraine with central pain syndrome. Although stroke, multiple sclerosis has been described, but this, I have the opportunity to go Paris. I described this type of pain, and so everyone applauded it. And there are a lot of editors, they are sending me to give this article to them. So migraine, because that much common in our having unilateral pain, always think of also migraine as a differential diagnosis. Clinical evaluation. So you have to write the pain intensity. It is not to satisfy you, it is also satisfying patient also. Because they are always saying, doctor, after treatment there is no improvement. So score the visual analog score initially. So how much you have out of 10? If you are having 7, if you are having 8, so then at the next visit you can ask them how much your pain score out of 10. Then by that only you can differentiate what is the improvement. So score is important. There are qualities of pain: stabbing, burning, sensitivity to touch. There are tingling, numbness, allodynia. This part, dysesthesia, this part is very much bothersome. Allodynia, non-painful stimulus giving pain, painful stimulus giving exacerbated pain, hyperalgesia and hyperpathia. This is more exaggeration. Chronic, small stimulation can produce long-standing pain. So peripheral versus central neuropathic pain. We know peripheral pain, trigeminal neuralgia, because cranial nerve, except optic nerve, they are included in the peripheral nervous system. So all the cranial nerve, except optic nerve, they can be involved. Trigeminal nerve, post-operatic neuralgia, peripheral nerve injury pain, post-amputation pain, painful polyneuropathy, painful radiculopathy. So these are the, what are the central pain? Neuropathic pain, spinal cord injury, central post-op pain, central neuropathic pain associated with multiple sclerosis. So these are the examples. the temporal variations. At the end of the day, pain becomes worse. Neoplastic process, there will be progressive increasing functional impact, all the part, sleep, mood, there might be suicidal ideations, sexual dysfunction, and attempted treatment. Neuropathic pain is resistant to NSAID because it is not that mechanism which is producing pain. Determine document adequacy of titration of the dosage. So start low, go slow. This would be the treatment for neuropathic pain. And search and distraction is not possible in the management of neuropathic pain. Why? Because you cannot cure diabetes mellitus. You cannot cure the disease already vasculitis. You cannot cure the disease process. So you cannot destroy the etiology. So that's why you have to start low, go slow. And you have to ask the patient, 100% recovery is not possible. If we think all the drugs are 50% effective. So how we can do that? If we multiply different type of drugs, we cannot improve them. So assure the patient about the seriousness, non-seriousness of the nature, and so that patient also be satisfied, and you at the end of the day, you will also be satisfied. So expectation of the patient, that should be tackled. So alcohol and substance abuse, few points. We are fearing to use opioids. Now why? Because there is nausea, there is constipation, there is ceiling effect, there is tolerance, there is substance abuse behavior. But who are the person who can have this drug addiction? Those persons who are already addicted to something. It may be smoking, it may be taking some preparations of sleep pill, it may be other way. So those are the patients who might be addicted to opioid group of drugs. Not all the patients. Because the study shows the patients who are taking opioids for neuropathic pain are not addicted to this opioid group of drugs. What are the difference between opiate and opioids? Opiate are natural. It is from opiates, heroin, morphine, codeine. They are opiates. What is opioids? So opioids are that drugs which are synthetic derivative of opiate, original morphine and that group. We have two important drugs, tramadol and tapentadol. So we can jolly well use this type of drugs. So physical examination, okay. So although we do the jug, but we have to test having the pin, having the cotton, and also having the pin, and also tuning fork. Because these three should be done. Even you diagnose by history, you have to examine the patient. It is not for my satisfaction, but doctor's satisfaction. It is satisfaction to the patient. Because you know, all things, 40% are placebo. Some patient is going to Dr. someone, and some patient is going to someone. Not maybe treatment is that much difference. So examination is a must, and you have to show that I have examined you and you have no seriousness in your nature. Sensory examinations, there are a lot of things which we can do. We can take one group of things. So these are the examination part, which is more important for student. Now, CT and MRI, obviously you know radiculopathy. Electromyography, nerve conduct study, it has some lacking. It cannot pick the small fiber, it only picks the large fiber, that means A beta and A alpha fibers. So all the patients having burning pain, and there should not be that much that its NCD study will confirm it. So three-phase nuclear medicine, clinical biochemistry is important, and the skin biopsy, which we usually do not do. And skin biopsy can count the nerve fiber, small nerve fiber, and also cornea conifocal microscopy. That can also count the nerve fiber also. So these are the tests: gesture, potential, blink reflex. So I request you that you can send the blink reflex, because blink reflex can easily pick up the cranial neuropathy early, particularly for trigeminal nerve and facial nerve. So differential diagnosis, you know that screening. So screening should be done for NITDM from ITDM after 5 years. For NITDM, it should be done every year. Comparison, there are leads assessment score, there are neuropathic pain questionnaire, there are dollar neuron 4 questionnaire management. So management, primary goal and secondary goal. So lot of drugs are available. Obviously TCA can have NNT less 3.6, but TCA has a lot of side effects. So TCA has been replaced by duloxetine and venlafaxine. And calcium channel alpha to delta ligand agonist, that is gabapentinoid. And topical ointment can also be helpful, capsaicin ointment, because some patients may suffer from focal neuropathy. So we can treat it. Tramadol, tapentadol is glorious tramadol. So tapentadol has less amount of serotonin syndrome, not like that of tramadol. Tramadol is 1/4 potency to the morphine. Tapentadol is half potency to morphine. So that means tapentadol is better tramadol. So you can use tapentadol instead of tramadol. So botulinum toxin, that special painkiller that can be used. There are a lot of mechanisms. There are descending modulatory pathway which have been mentioned by our chairperson. So first line treatment, always gabapentinoids. Opioid is second line treatment, except in cancer medicine, except in amputation, post-amputation. So combination therapy, obviously we are now using gabapentin combination with tricyclic antidepressant. We can use gabapentin with SSRI preparation. So these are the first line therapy. Cancer, neuropathic pain, phantom pain, post-traumatic pain, almost you can use gabapentinoid. But cannabinoids is coming. And panytoyl ethanol amide, which is also available. So cannabinoid can prevent nausea, can prevent chemotherapy-induced complication, can prevent spasticity, can be used in neuropathy. And panytoyl ethanol amide, it's not cannabinoid which is available, but it acts like cannabinoids. So it acts on anandamide receptor, which is obviously Indian in origin. It looks like CB1 or CB2 receptor. So there are interventions. This is out of our range. There are advantages, obviously non-medicines used, contraindications. There are problems in neuropathic pain management. So, can I have one case?
You have crossed your time.
One case only. So, this is 65-year-old man with history of diabetes, pre-diabetes, presented with numbness, unpleasant sensation, bed sit touch, physical activity. So the part of that, patient have multiple complications. Body weight, so sensation of pain because depression was started on duloxetine with improvement in pain, but he was still frequently up at night because of painful sensation. Gabapentin was added the night before bedtime. So thank you very much for exceeding my time limit. leaving the class, I must thank the audiovisual, I must thank the interns for their logistic support. So thank you very much. Thank you, Chairperson. Thank you, audience.
Thank you. Thank you very much, sir. If you have any questions, one or two questions, we can allow.
I have a couple of comments. Number one, thanks for your in-depth description of neuropathic pain. Certainly, when we deal with a case of neuropathy in diabetes, diabetes should not be taken as the exclusive cause. We should be allied to other causes. While treating patients, we should counsel them properly because we can't cure 100% of the cases. Thirdly, EMT NCB that we do routinely picks up only large fibers and pain is observed by small fibers and not picked up in routine EMT NCB, and skin biopsy is important. And fourth point where I differ from the Professor Romesh Bhattacharya is that diabetes mellitus is not the only condition where multi-specialty converge. When we were medical college students, we were taught venereal diseases such as syphilis was a common cause of involvement of several systems of the body. With the control of venereal diseases with antibiotics came the realization that connective tissue disorders such as SLE had multi-system involvement requiring convergence of multiple specialties. And now we have autoimmune disorders where multi-specialties can converge. Any comment or one or two short questions from the audience?
Thank you for the nice presentation. But just one query. How is your experience with the topical application of the pain management practice?
Thank you very much for these important questions. Because I feel that there are a lot of pill burden in the patient. Patients are taking antihypertensive, thyroid medications, and other medications for various purposes. Now, if we give some cream preparations already available, there are some preparations we having gabapentin and also analgesic preparation and ketoprofen or that sort of thing, fentanyl, that sort of thing. I am using that, particularly for focal neuropathic pain, like that of getting the neuralgia prosthetica, post-herpetic neuralgia, and also only the sole of the foot is involved in diabetes mellitus or other causes. I am using it, but definitely not a monotherapy, because I am using it associated with systemic and oral therapy. And it not that much that it will improve every patient, but no doubt some of these, some subgroup has improvement. There are capsaicin preparation which are available.
Is there any difference between the application of the ointment or creams and the patches?
Yes, the patches are that. There are some patches which act locally, and there are some patches which act systematically. There is fentanyl patch, they are systematically. And there are some patch, lidocaine patch, they are acting on the same site, like that of post-herpetic neuralgia have the lidocaine patch that can be used, that is also available in India, so that can be used. I have used that also for post-herpetic neuralgia.
What is your experience with the claudication type of pain?
Yes, the claudication we divide into two ways, vascular claudication and neurogenic claudications. So as a neurologist, I do neurogenic claudication. So this is basically narrowing of the spinal canal that can be dealt with all the things we do for radiculopathy, exercise, belt, pregabalin garment, immunodepressions, weight for 2 months conservative management. Then we assess, and then if there is no improvement, we do surgery. But
Thank you, sir.
Yes.
Thank you, sir, for the elaborate discussion. Now we close the session and hand over mic to the organizers. Thank you.
So, only one comment, sir. Because of this hallucinatingly changing world, every household now suffering from diabetes mellitus. So, syphilis is not that much nowadays, and autoimmune disorder are obviously common. But I think diabetes is every household, you see every household suffering from diabetes.
Exactly. It is the most common cause of peripheral neuropathy. Thank you, sir.
Thank you.
Thank you, speakers and chairpersons. I would like to take a moment for the felicitation, a small token of appreciation from Howrah Diabetes Study Society. Sir, please may you come in the middle of the stage. On the eve of Mahalaya, Ma Durga for you.